everyone. I hope everyone can hear me. I'm suffering from a bit of a hoarse throat today, but I think we're going to power right through it. Thank you, everyone, for joining us for the latest session of the DaVita PD webinar series. Our series covers the key clinical elements of managing patients on PD and is recommended for all DaVita medical directors, neurologists, and nurses who plan to have or actually have patients right now on PD. Today's audience is a really good mix of physicians and DaVita teammates. I'm happy to see that there's such growing interest around the therapy. We should have about 150 people on today's call, but we'll have plenty of time to get to questions from everyone if you'd like to ask them. For nurses in attendance, you are eligible to receive one continuing education credit for today's presentation, as well as one credit for each of the previous webinars in our series. Since this is the second one, that'll give you 2 CE credits, including today. As a reminder, all of our webinar sessions are recorded and they're available for on-demand access. We often reference previous webinars and our current webinars, so feel free to go back and watch the past ones as a reference. Today's session, like I said, will include a Q&A session at the end. You can ask questions in multiple ways. You can wait until the end of the presentation and ask your questions in person, or you can type them in the chat box of your webinar panel. Go ahead and ask those questions for you. So let's go ahead and get started. Today's topic is managing comorbidities in PD patients, and we're going to talk about hypertension and congestive heart failure. Now go ahead and hand it over to Tracy Milligan, who's Senior Director of Clinical Services. Tracy is going to introduce today's speaker. Tracy?
Thank you, Ayla. I'm very pleased to be able to introduce to you Dr. Rajnish Mehrotra. He's a professor of medicine and the section head of nephrology at Harborview Medical Center at the University of Washington in Seattle. He studied medicine in both India and the U.S. and completed residencies in both internal medicine and nephrology. In 2008, he earned a Master of Science in Clinical Research from the University of California, Los Angeles. He is the Education Committee of the International Society for Peritoneal Dialysis and is a member of the Board of Directors of the International Society for Hemodialysis. He is an active member of and holds positions with the American Society of Nephrology, the National Kidney Foundation, and the North American chapter of the International Society for Peritoneal Dialysis, among others. He authored or co-authored over 130 peer-reviewed research papers and published or co-authored hundreds of articles, newsletters, and book chapters. His research interests included adherence of dialysis patients to therapy, determinants of selection of dialysis modality, and outcome studies in peritoneal dialysis. He was a featured speaker at the DaVita Physicians Leadership Meeting in 2012 and is a veteran presenter in this PD webinar series. Dr. Mehrotra recently relocated to the Seattle area with his wife and 2 children. Dr. Mehrotra, it is now over to you.
Thank you, Mahela. So we'll talk about the issues of hypertension and congestive heart failure in patients treated with peritoneal dialysis. And I begin with a disclaimer that the content and opinions of this presentation are mine and do not necessarily express the views of DaVita. Get into the talk. I think the things that we've learned over the last 2 or 3 years, if you look at the long-term survival of patients that are treated with PD, no different from that of those that are treated with hemodialysis. And a slide from a study that we looked at recently, looking at 5-year survival, and there was absolutely no difference either early on or later on in survival of patients treated with hemodialysis and PD. And that suggests you follow these patients for up to 10 years. And as you can tell, that the 10-year survival of patients that started in 1999 that have been followed through 2009 is identical in those that started treatment with hemodialysis versus PD. That's the good news. There is bad news in this slide as well. Is the average life expectancy of a patient starting dialysis is only a little over 3 years. At 10 years, 12% of patients that start dialysis are alive. patients, even though the two therapies are similar, the survival of these patients is not very good. To build on that theme a bit more, I think it is important then for us to understand and recognize that one of the key things that results in our patients suffering a high risk for death or high need for hospitalization is cardiac disease. They get cardiovascular disease. And if you get, of all patients that died, started treatment between 2008 and 2010, over 30% of them died because of a cardiovascular cause. And if you look at of all the reasons why our patients get hospitalized, the largest reason why they get hospitalized is a cardiovascular cause. Almost one of the reasons why our patients get admitted, and these is talking about patients treated with PD, it's because of cardiovascular disease. Recognizing the importance of cardiovascular disease in determining the outcome of our patients treated with PD, we're going to focus on two things today. The thing is hypertension. Is why should we care? What should the targets for treatment be? And how should we treat high blood pressure? And then congestive heart failure. And the question that I'd like to answer there is whether there is an advantage of PD or hemodialysis in people that have congestive heart failure, and wrap it up with treatment strategies. So start then with hypertension. So hypertension, as we know, in people with kidney disease is highly prevalent. All the patients who started dialysis treatment for a 4-year period between 2002 to 2006, over 80% had a history of hypertension, and when they start treatment with dialysis. And as you know, that on dialysis, almost 90% or more patients have hypertension and need some form of treatment for hypertension during the course. We don't know that in the general population, higher the blood pressure, greater the risk for death. And so we know in people without kidney disease, we try to aggressively control blood pressure. The question is, should we try to aggressively control blood pressure in people that are on dialysis? And the data on that, in terms of the studies that have looked at this, are very clear-cut. And if you see, most of the studies in those studies looks like this, that as the blood pressure goes up, the risk for death does not go up fast. In patients whose blood pressure is less than 110, so if you have the blood pressure too low, they have much higher risk for death. So one could reasonably ask a question. Yes, we know that high blood pressure is important in people not on dialysis, but does a study like this, why do I care about treating high blood pressure? Problem is, in part, in where we started. We started in the fact that the reasons why our patients are dying in 3 years, 3 years of starting dialysis. And so patients don't live long enough for us to see in a study like this that high blood pressure is bad. Contrast, I'm not going to walk through all of these lines that are on the slide, and I want to illustrate an important point. And the reason why our patients don't see an association between high blood pressure and risk for death, because our patients come in very ill and they die. Instead of relatively healthier, and the healthier the patient, the faster they're going to get onto a transplant waiting list. And the CWL is a transplant waiting list for less than 6 months. And if you the patients that get earliest onto transplant waiting list, and if you follow them long enough, high blood pressure is a risk for death. I am convinced that a high blood pressure in dialysis patients needs to be treated if our overall goal is for our patients to live as long as they can. And indeed, and then blood pressure should be controlled. Having come to the conclusion that the blood pressure needs to be controlled, the question is, what do we want that blood pressure to be? And there are no good studies, again, to make any firm recommendations on what the blood pressure should be. And I think the general principles are these two, that pressure should be less than 140 over 90 millimeters of mercury. That's our target that defines blood pressure. So I don't think it should be 150 or 160 or 170. It should be less than 140. The top number that we usually struggle with, not the bottom number. Having said that, you do not want the blood pressure to go too low or the patients to get dehydrated. Clinical practice that we find is that we should strongly encourage our patients to measure their blood pressure at home every day. And depending upon how they're being treated, they either write their blood pressure on a piece of paper, or if they use a home choice pro machine, for example, or another in which they can electronically record it. And then would our patients, as a part of the monthly visit to the physician, bring in the home blood pressure record, review what the blood pressure is, and make adjustments if you're not at 140 over 90. I think this is extremely important. I think measuring blood pressure at home is more important than the blood pressure that you get in a dialysis facility, particularly for a patient who's on home dialysis like a PD patient is. The principles of management. So we talk about the issue of physical exercise and weight loss, and I'll just very briefly talk about that. We encourage physical exercise, particularly aerobic exercise, the one thing that you have to be careful about in lifting heavy weights. The other thing that you have to be careful about is if the patient engages in exercise that makes them all sweaty, right after they finish exercising, it is absolutely critical they take a shower and do the routine exit site care. You do not want a wet, moist dressing over the exit site because of sweating, because of rigorous exercise. This is difficult, and given the fact that larger people on dialysis do better, we do not focus much on weight loss. Weight loss does become a barrier at times for transplantation, but in the context of hypertension, at least, is not a treatment approach that we use in our practice. Important is absolutely the management of the volume status of the patient, and I'll focus on salt intake, residual renal function, and the management of the peritoneal prescription, and briefly touch upon drug therapy. So a slide from almost 10 years ago. This is a study from Turkey in which almost 50 patients treated with CAPD, and they imposed strict sodium restriction, and with alone 20 people became normotensive. Of 7 that remained hypertensive, if they increased ultrafiltration, 17 additional patients became normotensive. 7 of 47 patients became normotensive by restricting diet in the diet and by increasing ultrafiltration. Only 7 of these individuals needed a blood pressure medication, and if you indeed there's 3 that would need as well as 10. So I am not making a case for a very aggressive ultrafiltration strategy. I'm making a case that we have to find the right balance in ensuring that the patients are not eating enough salt and are ultrafiltering enough for them to remain eulemic. And if they remain eulemic, you have an easier time controlling the blood pressure. What you don't want to do with excessive ultrafiltration is to volume deplete an individual for them to get hypotensive and for them to lose residual kidney function in the process. About salt. When I was doing my fellowship, I always heard that one reason why patients should do PD is because they can eat and drink what they want. Not true. We learned that not this study. This is a randomized controlled study in which the patients were asked to take their usual diet and into that 6 milliequivalents of sodium chloride. And as you see, when they took that, their blood pressure went up 9 points, the systolic blood pressure went up 9 points, and their diastolic blood pressure went up 5 points. So the pressure will go up. So PD does not allow for unlimited intake of salt and water. And so the patients that are treated with PD need strict salt and water intake just as much as patients treated with hemodialysis do. And I just feel very strongly about this, is that none of us should tell our patients that if choose PD, salt and water intake can be more liberal. That is simply not true. What is true is that they can eat potassium more liberally, so they can have fruits and vegetables more readily. But salt is not one thing that they can eat more readily, and we have to be as careful about restricting salt intake in patients treated with PD as treated with hemodialysis. Along is that volume overload is an important reason for high blood pressure in patients undergoing dialysis. This is true for patients on PD, and it's true for patients in hemodialysis. I've already shown you some data that if you control volume status well, you have a better time controlling patients' blood pressure well. And if you control the volume status and blood pressure, it have all these effects on residual kidney function, on heart, and all of that that we concerned about, given the high risk for death and hospitalization in our patients. In addition to restricting salt and water, what's important is to maximize the salt and water that is removed from the kidneys. Kidneys are our friend, and we need to make them work. And the approach is to use diuretics. And diuretics would be drugs like furosemide or Lasix, torsemide, or metolazone, or whatever there is. And this is a clinical trial that was done in England, in which patients were randomized to receive either 250 milligrams of furosemide or usual treatment, and see at the end of 1 year, patients that were given furosemide had a net urine volume that was 350 cc's higher than those who did not get furosemide. So it is, I think, important for us to optimize the use of diuretics. I am not advocating use of doses as high as 250 milligrams. It is what needs to be determined is what is the dose for ungiven patient that increases, that the patient can tell you that if I take this dose, my urine volume goes up. Whether that is 40 milligrams, 80 milligrams, 160 milligrams, whatever that is, the patient needs to take it and then report back to us that the urine volume went up. If the urine volume went up, that's the dose you want to use. And that is rather than using some fixed dose regimen that you have. Go on then the second important thing is to use drugs that block renin-angiotensin system. And this is a clinical trial, again, in patients treated with PD, randomized either to a control group or to a group that is treated with ramipril. And these patients, as you can see, those that were treated with ramipril have a slower decline in residual kidney function compared to the control population. Similarly, the time to anuria was faster in patients who did not get ramipril compared to the controls. So another clinical trial that has looked at this is to look at valsartan. Valsartan is an angiotensin receptor blocker. And you can see, again, this is a study done in patients treated with PD. Those that received valsartan had a higher creatinine clearance compared to those in the creatinine clearance went down over time when treated with a placebo. So it is one of the advantages in using drugs like ramipril or valsartan, it depends on PD. Because there is no potassium in the dialysate, they do not get a high potassium as a side effect of the drugs. So have a patient who has chronic kidney disease who has been treated with medications other than ACE inhibitors and ARBs, and they have been taken off those medications because before they started dialysis, their potassium level was too high. Why start PD? You can gradually reintroduce those medications because they're less likely to get into trouble because of a high potassium. And so what we find very useful is that we create a checklist of things that we're doing at every clinic visit, and checklists that we had is the patient on ACE inhibitors or ARBs, and physicians had to answer yes or no. And the reason why we did that is not because we don't know that these drugs are good, because there's often we get busy and distracted and this may not be on a radar screen, if you checklist that checks whether the patient is on ACE, ARB, yes or no, and you force a physician was forced to answer that every time, is more likely to make sure that 100% of our patients were on drugs of this kind, which I believe they should be, unless there is a reason that they cannot tolerate medication, they get side effects, that they're not on those drugs. But it is a good practice for you to check every clinic visit if the patient should be on ACE-ARB, and if should be on ACE-ARB if they are on ACE-ARB. That I think is very important. In giving medications that are positively helpful, it is important to avoid things that are harmful. That are harmful for residual kidney function are things like radio contrast dye. So if they are going to get a cardiac cath, or if they're going to get a CAT scan of the abdomen and they're going to give contrast, you have to be careful with that. Glycosides, things like gentamicin, tolmicin, medications of that kind. Painkillers, particularly because they are available over the counter. Patients can go and get non-steroidal medications like Aleve, like ibuprofen. They can get those. They are harmful for kidney function, and we have to keep our patients away from those. Episodes of volume depletion. Urinary tract obstruction in people, particularly elderly men that may have a large prostate, that may result in problems with kidney function. Hypocalcemia in people that are getting vitamin D or calcium-based binders, be sure that the calcium does not go up. And finally, patients that have had a transplant, once the transplant fails and when we start PD, we as a routine leave at least one immunosuppressive medication on board, whether it was a small dose of mycophenolate mofetil, or is it a small dose of tacrolimus, which is FK506, we would make certain that we do not completely stop all those medications. They do not increase risk for infection. So of course, you have to be careful, but that is an important strategy in preserving kidney function. On to the PD prescription. I think what is important when you're talking about the PD prescription is to focus on the long dwell. So depending upon what therapy the patient is on will determine when the long dwell is. Somebody who's doing a cycler treatment, this nighttime cycles are short. It's daytime dwell that is long. And so when you evaluate a patient on a cycler, what is important to know is what is happening in this long dwell. If the patient has only a single 14-hour dwell, the best to find out is what's happening with that eye drain, the initial drain the patient has when the patient connects to the cycler. So if the patient is putting in 2 liters in and drains 17 or 1600 ml out when the patient connects to the cycler at night, that's a problem. And so in any patient who has volume overload, for you to look at that eye drain is very important. Similar in people on CAPD, there are 3 manual exchanges at night. In the daytime, it is that long dwell is the overnight dwell. So you want to know for a patient on CAPD what the drain volume is in the morning when they wake up. That would be the critical issue with regards to the prescription management of a patient doing CAPD. That drain in the morning when they wake up. So that drain when the patient connects to the cycler, the morning drain for a patient on CAPD. A patient has a long dwell, has a midday exchange, you want to know what's happening in that midday exchange. And the long dwell is important, is something that we understand. It's because glucose is what we use for ultrafiltration that is absorbed during the course of the long dwell, and that happens as a result of which the volume of ultrafiltration goes down over time during the course of a long dwell, so that there will come a point in time during the course of the dwell where the patient will start to reabsorb fluid, that you would put in more, less would come out. Now, at how many hours that will happen will depend upon the concentration of dextrose that you have. So it's 1.5%. It's going to happen sooner compared to 2.5, compared to 4.25, or depend upon the transport type of an individual. Same concentration, fluid absorption will begin sooner in the course of a dwell, a patient who's using who's a transporter compared to that who is a low transporter. So recognizing that long dwell is important, the question is how do we manage that? And principles are very simple. You have three choices, and those are the three choices. You can shorten the duration of the dwell, you can higher concentration of dextrose, or you can use icodextrin. Those are your three choices. So in a patient who's reabsorbing fluid, due course of a long dwell, in CAPD, that patient in CAPD wakes up in the morning and drains less fluid than they put in. In that patient, you will see two things. You can see whether you can change the timing of an exchange. So if you're just using 1.5% dextrose, for example, if you go from 12-hour dwell to an 8-hour dwell, you can substantially minimize the amount of fluid that is reabsorbed. So you choose to stay with 1.5% and see if the patient has. You want to let the patient get enough sleep. You don't want to have the patient wake up. But in those constraints, you may want to see whether you can change the timing of an exchange. Or if the patient has significant residual renal function, you may just give them a dry night. They do 3 or 4 exchanges in the day and have no fluid overnight. And that's completely acceptable as long as they have residual kidney function. Or use a higher concentration of dextrose. If they're using 1.5% dextrose, you want them to use 2.5% dextrose overnight. What I would not do is them use a 4.25% every night. That is something that is, in my opinion, a complete no-no because of risk for damage to the peritoneal membrane. If they want to use 4.25% dextrose a few weeks, that is okay. But if on a daily basis, I think that there's not a good clinical practice to be using 4.25% dextrose on a daily basis. Patient on a cycler. The patient cycler, we've already said, the long dwell is the day dwell, and so do we manage the day dwell. So the things that you have to be careful first about the time is sure that you don't do frequent cycling. The reason why you don't want to do frequent cycling in this context is because if you do frequent cyclings, you remove water, but you remove much sodium. This is the amount of sodium. And that's because water is moving through these water channels that are in the cells, which are aquaporins. So if you do rapid cycling, if you're doing 5, 7, 8 cycles at night, then you're moving water, not removing sodium. Sodium that is left behind in the blood, that will simulate thirst, and the patient will drink more the next day. So a clinical practice for nighttime prescription of a cycler is to use 3 or 4 exchanges overnight, not 5, 6, 7, and 8. Long day dwell. The principle is the same. Shorten the duration of dwell or increase the concentration of dextrose. And illustrated right here. If you shorten the duration of dwell from 15 hours to 10 hours to 6 hours, you will get more ultrafiltration. 1.5% or 2.5% would be better. So if the patient is using 1.5% during the day, you can change that to 2.5%. Now shorten the duration of dwell. You can duration of dwell in one of 2 ways. You can, of course, one of the choices we've already talked about is if you're using 1.5% dextrose, you can use 2.5% dextrose. But alternatively, you can, when you shorten the duration of dwell, you can either have the patients do an exchange in the middle of the day. Now, it have to be the middle of the day. It doesn't have to be 7.5 hours. It could be that this exchange is for 6 hours and this is for 9 hours. Each one of them is shorter than the 15-hour dwell that they had if they're doing the cycling for 9 hours overnight. Or in people that have a significant residual renal function, you give them a partially dry day. Have them wake up in the morning and 2 or 3 hours later drain the abdomen and be dry the rest of the day. And that give them, but the only time that you do that would be when patients have significant residual kidney function. If they don't, you do not want a partially dry day. Those model numbers is that when you go from a 15-hour dwell to a 6-hour dwell, which is a partially dry day, and this is a day exchange. Of course, if you do a day exchange, you have the greatest gain in ultrafiltration volume and also the greatest gain in clearances. And in my opinion, for the most part, is a preferred approach. But this is also a completely acceptable approach is to give a partially dry day in people with significant residual kidney function. Our facility where I was Los Angeles before I moved to Seattle, we would almost never use 15-hour dwell with dextrose-based solution alone because of concern about fluid overload. In addition to changing the duration of dwell or using a more concentrated dextrose solution is to use icodextrin. Icodextrin, of course, if you have a long dwell, is superior to 4.25% dextrose. And this is just to show that it doesn't matter what compare solution you use, whether it's 1.5, 2.5, or 4.25, if you have a long dwell meaning that the dwell time is longer than 8 or 10 hours, you have much greater ultrafiltration compared to any of the glucose-based solutions. Now, I'm not saying that icodextrin needs to be used in every individual in the long dwell. No. It is that individual who, for some reason, is either not able to do a midday exchange or who does not have significant residual kidney function so that you could not give them a partially dry day. Even if you give a midday exchange, they're still reabsorbing significant amounts of fluid. I personally don't look at the PET results very much. When deciding who should get icodextrin, I actually see what is happening with given prescription to a patient. So I have somebody who has a midday exchange, and they're still absorbing fluid. To me, it doesn't matter what the D over P creatinine is. I would give a trial of icodextrin in that individual. So icodextrin is for a small proportion of patients that would get advantage in that regard. And one of the advantages that I see with icodextrin is that the net absorption of glucose, because it is metabolized to glucose for every volume ultrafiltration, is not very large. I'm just going to skip this slide. So guys, in terms of management of hypertension, it is the restriction of salt and water, manage urine volume, and protect residual kidney function. PD prescription, you have to have a close and routine evaluation of daily home UF volume. With regard to drugs, ACE ARBs have to be the first-line therapy. In people with residual kidney function, you add a diuretic. And else, in my mind, are all equal, as indicated or tolerated. Rounding this up to congestive heart failure, some elements that I've already covered are relevant here as well. Congestive heart failure is common in people that start dialysis. In the United States, if you look at all people that start dialysis, almost a third of them, all these years, have had heart failure or a history of heart failure when they stop. So it's a common problem in our dialysis population. And it is important to understand is that not only, so these people that have a history of heart failure, get heart failure again when on treatment. Firstly, those who never had a history of heart failure get heart failure also. And a study from Hong Kong in which they had over 200 PD patients, just like in the United States, this is slightly higher than the United States. Almost 40% of patients here have a history of heart failure. But of those that had a history of heart failure, almost 2/3 had a recurrence. But in those that never had heart failure, almost a quarter had heart failure. So as you see, over a third, almost 40% of patients that started PD will, during the course of the core PD, will get an episode of heart failure. So it's a common clinical problem that we need to watch out for when evaluating our patients. So the question is, in people with heart failure, is hemodialysis better or is peritoneal dialysis better? And I do not come to a conclusion that one is better than the other. There are advantages of hemodialysis, there are disadvantages of hemodialysis. Similarly, the advantages of PD, there are disadvantages of PD. So in hemodialysis, you can predict how much fluid you will remove with each session. They are seen by staff 3 times a week. There are a variety of interventions that we can do if the blood pressure goes during dialysis to control the blood pressure. So you could say there are potential advantages of hemodialysis. Now, there are, of course, disadvantages also, is because of the issue of the blood pressure going down, and if the blood pressure goes down during treatment, hemodialysis, you may not remove enough fluid. With PD, the issue clearly is this gentler, more sustained ultrafiltration. You preserve residual kidney function longer in patients on PD than on hemo. And then you can use all of these medications that are good for the heart that you'll be able to use if the patient is doing chemo. Just things like ACE inhibitors and ARBs because of issues with regards to potassium. The advantage of PD is because so hemodialysis, you can actually dial in a number for removing fluid, and you will get that. If you cannot dial in that number, it is a teamwork. It is a teamwork between the nurses and the physician and the patient. And then in the end, the patient has to make all those adjustments that they have to make. So we're more dependent upon the patient. Having said all of that, you can see that there are unique advantages and disadvantages of each therapy, and you have to figure out which one works for which patient at which point in time. And I'm not going to argue that PD is better or hemodialysis is better. There are all of these studies that have looked at that. For example, the study from France that showed that if you have a person with heart failure starting dialysis and you start them on PD, they have a higher risk for death. And I'm completely uncertain what higher risk for death is because of PD. It could be the sicker people will preferably put on PD because there's perceived advantages of gentler ultrafiltration, and is because they had sicker and more severe heart disease is the reason why they died earlier and had nothing to do with PD. So just to be very careful, I would give patients a free choice and have no bias in terms of which approach they use. There are all studies like that. If you look at patients that start PD or hemodialysis and see if you follow them over time, who gets readmitted for heart failure, this is an old study that showed that patients that started treatment with PD were much less likely to get recurrent heart failure or new heart failure compared to those that started chemo. The issue then is if I personally come to the conclusion that it has advantages and PD has advantages and patients should choose what they want, once patients are on PD and they have a history of heart failure, what can I do to prevent them from getting heart failure again? And this just shows the two important things that we've talked about. Each of them is interrelated. One is the issue of control of blood pressure. Higher the blood pressure, more likely the patient is to get readmitted for heart failure. So we talked about control of blood pressure as one strategy. One of the advantages that you get is you prevent heart failure. Then there's left ventricular hypertrophy that gets back to the issue of controlling volume. It's just a clinical trial that resulted in an improvement in left ventricular hypertrophy. So this clinical trial, people on CAPD were randomized to over-dwell to use either 1.5% dextrose or icodextrin. Now with icodextrin, there was a regression in left ventricular hypertrophy, and that happened because their volume control improved. I want to be very clear. I am not saying that every person who has left ventricular hypertrophy should get icodextrin. No, that is not my point. My point is the focus on volume management. Icodextrin is one tool to control volume, but the general goal, the big goal, has to be control volume, whether it is by using higher concentration of dextrose or giving people a partially dry day or a midday exchange or using icodextrin or preserving residual kidney function. Each one of those, in my opinion, is good with regards to left ventricular hypertrophy and would be good for heart failure. The principles of management are generally the same: salt and water management. We've already talked about this. We've talked about the importance of the diet. We've talked about the importance of residual kidney function and peritoneal prescription. We've also talked about ARB. We've talked about ARB being important for residual kidney function, but they're also good for the heart. It's okay to use digoxin. And a good clinical practice is if a patient is on digoxin, incumbent upon the team to monitoring digoxin levels. You can have it needs to be done either in the dialysis facility or patient's cardiologist. Whoever is doing it, the whole team needs to know that is being done. You can just assume that somebody else is checking it because they think that we are checking it. So there needs to be that communication and understanding as to who's checking digoxin levels, because there is a lot of evidence that we do not do a good job in giving digoxin. An important point I want to make: there are other drugs like beta blockers, spironolactone, and risk factor modification I don't have time to talk about. It brings me to the end of my talk, and what I've tried to say in the last 40 minutes is reducing cardiovascular risk integral to successful management of PD patients, is as important as preventing peritonitis. Clinical assessment of volume status, and the addition of daily ultrafiltration, critical component of reducing cardiovascular risk. This is for that patient to bring in their home records, whether it is in the form of paper records for a patient on CAPD, or use a machine like a Home Choice Pro that you download the data from. Any of those are very important in making that happen. And P can be successfully implemented in patients with a previous history of congestive heart failure. To the end of my presentation, and be to take any questions or comments that you may have.
Thank you so much, Dr. Mehrotra, for that presentation. Sarah, would you please compile questions for us?
At this, if you'd like to ask a question, please press star, then the number 1 on your telephone keypad. Previous question queued up from Gail Barosa. Your line is now open.
Sarah?
Question queued up is from Maria Higa. Your line is now open.
This is Nelly. I just have a question regarding the creatinine of our PD patients. Is it high when they pass the adequacy?
So in people on dialysis, whether it is on dialysis or on PD, creatinine reflects two things, and neither of the two kidney function. One, it reflects the muscle mass, so the more muscular individual will have a higher creatinine, and the second, it will reflect the intake, the food intake of full muscle, which is meat. So a patient who's eating a large amount, for example, of meat will have a higher creatinine than somebody who does not. And as you can see, neither of the two anything to do with residual kidney function. This is how the new steady state that we come to. In fact, there are some studies, including one that we've used the DaVita data from, that show that higher the creatinine in a patient, the live. This is for hemodialysis patients. This is PD patients, because those are the healthier patients with large muscle mass. I would not use the serum creatinine level as a measure of kidney function in on dialysis, whether hemo or PD. The thing that concerns me with regards to the adequacy of dialysis actually is a high BUN. It is adequacy of dialysis or patient adherence. People that are not adhering to the prescription, they'll do a 24-hour collection for you, and they don't. But before that and the day after that, they didn't do their PD. They have high BUNs, and that's what I worry about. So creatinine, I wouldn't worry about.
I have another question, please. Do you think patient can be good in PD?
No question about that. They actually, I should have taken a picture of this. There's a high school football player, or maybe he was an NFL player, who had end-stage renal disease, and there was an issue of Sports Illustrated with big muscular man with a PD catheter hanging out of his belly. So the short answer is absolutely yes. You have to be careful about making sure that they're not lifting heavy weights, and that you do exit site care after they exercise, things of that kind. But no question that they can do it.
Thank you.
There are no questions queued up on the phone lines at this time. Oh, one question that just came in from Shannon James. Your line is now open.
Thank you. My question is, I have a patient that is having a problem with fluid overload. I just started him on extraneal as his last. Well, he is a cycle patient, but he's currently doing on the machine 6 cycles plus the last dual, which is the extraneal for the remaining portion of the day. Is that a suggestion? He's using 2.5 as his regular percentage.
So So we have to be careful. I mean, yes, I mean, in short, that potentially is a good prescription. What needs to happen is for you to be looking at the ultrafiltration volume, both overnight and with the long dwell. So in general, I skipped one slide, and I just want to maybe make that point now, is that in general, we think that the longer the dwell time, the more the ultrafiltration with icodextrin. It's true for the most part. However, there are some patients who actually absorb icodextrin fast also. So if you have this patient, for example, using, let's say, a 2-liter fill volume in the day, and you look at the eye drain, and their eye drain is 1800. One strategy that you may want to use is to break down shorten the duration of the dwell. Instead of having 15 hours, shorten it by, let's say, 8 or 9 hours. And there's potentially a gain in ultrafiltration. And when you do that with icodextrin, what you're doing is you'll add a dextrose exchange as a second exchange. So the incremental gain in going from 4 exchanges to 5 or 6 exchanges overnight is not very large. There is a gain in ultrafiltration, but the ultrafiltration gain is not very large. So I just don't see much reason to go beyond 4 or 5 exchanges overnight. Personally, bottom line is that it's a good approach to begin with. Be ready to adjust based upon the patient's response to that prescription.
Okay, thank you much.
Further questions queued up at this time.
Go ahead and take a question from our chat box here. The question is, Dr. Mehrotra, what do you consider too high a volume of absorption on a long day dwell without a high dose? For example, the last fill, if it's 2,500 cc's and the interdialytic volume is 2,000.
Yeah, there's no good science behind this for me to come up with a number. And I tell you that I'm concerned if the patient is absorbing more than 200 or 300 cc's. So if the 2,500 is a fill volume and the drain volume is 2,200 cc's or less, I'd be worried. Now, having said that, anything that we do have to be looking at in the clinical context. So, for example, the patient may be absorbing 200-300 cc's during the day dwell. They make 2 liters of urine. They're making another 500 cc's of ultrafiltration overnight. I'm worried in adjusting the prescription in such a patient compared to someone who just has 300 cc's of ultrafiltration or maybe 500 cc's of ultrafiltration overnight, and they absorb 200 cc's during the day, and they have only 100 cc's of urine that they make. So what would trigger for me to change the prescription will depend upon the nighttime ultrafiltration, as the residual kidney function, and the clinical condition of the patient.
Thank you. There are more live questions out there.
Again, to ask a question on the phone lines, please press star 1 on your telephone keypad.
Wait, I'll go ahead and grab one from the chat box here. Mehrotra, if a patient has a very, very low renal function left, they have about 100 to 200 milliliters per 24 hours of urine. It lasts. Make sure I can read this correctly. I guess this person is trying to figure out a way to continue to preserve renal function.
The urine volume is less than 100 cc's. Lost for this part. I mean, if the patient can, I would still continue angiotensin converting enzyme inhibitors, angiotensin receptor blockers. I would not have much hope in terms of to have much clinical value at that level.
Thank you. Questions?
Questions queued. Oh, sorry, one's just queued up from James. Your line is now open.
I have another question, doctor. I have a patient that is basically maxed out on his prescription. He's cycler at night and 2 exchanges in the day. Very compliant patient. His adequacy, his clearance is good, over 2.0, but his creatinine is high consistently, his albumin is low, and his phosphorus is high consistently. Other dietary restrictions, what else can we do for this patient?
So, as I said earlier, I wouldn't worry about the creatinine. So here's the issue of albumin being low. That are doing PD lose protein with PD, and most important protein that they lose is albumin. So on an average, a patient on PD has a low albumin relative to a patient on hemodialysis. Then the question that follows is, if the patient's albumin is low, should be worried that the albumin is low and I should switch this patient to hemodialysis. And I think it's a theme that I've articulated before. Would never make that decision based on albumin alone. I would make that decision. So creatinine I don't care about. And the only thing that I've heard that is not good is the albumin issue. We'll get to the phosphorus in a minute. Is going to be albumin in context of a patient who is not feeling well, that the appetite is low, that they're losing weight over time, or they have nausea and they are vomiting, or they have diarrhea. In that context, I'm worried because I think that I need to do something differently, whether it's with regards to PD or switching them to hemo. But if it's the only thing that is abnormal and everything else looks good, if the only thing that's abnormal is an albumin, it is a goal. It is the way at least I practice. I would just follow them along without making any change. The phosphorus, in terms of the removal of phosphorus with PD, is the same as with 3 times a week hemo. It's not as if switching them to, unless you plan on doing hemodialysis every day, the phosphorus that you will remove with hemodialysis is the same as with PD. So in this patient, I've really heard nothing that would prompt me to say that PD is not working. I speak to the general population of patients or all the other issues that this patient may have. A lot of these judgments have to be made in the clinical context, and albumin alone is not enough for me to worry. I just don't worry about a low albumin if that's the only thing that's abnormal.
Thank you, doctor.
Is there another live question?
You do. Next question comes from Patricia McCorrell. Your line is now open.
Yes, this goes back to the patient with the low albumin and just a question about an approach that we use. Doctor, what do you think about actually prescribing this person to scramble 3 egg whites twice a day as a readily available source of albumin, and you leave the yolks out so we don't run into the cholesterol problem?
I'll say 2 things to that. If the patient can really take that scrambled egg, that's good. I'd encourage that. Higher protein intake is good. But I get back to the point that I made. I just isolated low albumin does not reflect low protein intake. So to match protein intake in general is a good approach. And in terms of increasing protein intake, a prescribe is a good approach. I wouldn't be other reasons why the albumin could be low other than a low protein intake. I have not even gone into the details. For example, in patients that have significant residual kidney function, all kidney diseases that we get, patients build protein in the urine. That could be the reason why their albumin is low. We've talked about the loss of protein in the PP fluid, which there's no evidence that protein that patients lose in the PD fluid is actually harmful to the patients. There is no evidence that we have to make up for it somehow. So I use my clinical judgment and albumin alone, and I treat those two issues differently. High protein intake is a good approach, and which is a good approach.
So look at the whole picture, really, is your answer.
Exactly right.
Sir, thank you.
Questions queued up on the phone lines at this time.
We'll take one from the chat box here. Dr. Mehrotra, is there any value of using diuretics with a urine output of 500 cc's or less?
I mean, I know 100 cc's is kind of cut off. 500 cc's is plenty of urine volume. I will absolutely use diuretics in that setting.
Great. One more from the chat box here. Dr. Mehrotra, for a diabetic patient, when do you recommend the patient do their AccuCheck on a dwell for better control of their diabetes, especially if the patient is using 2.5% fluid retention?
Yeah, so that's tricky. That's a trick question, and I don't know if I have a good answer in that regard. At least the way to approach this issue is severalfold. If the patient has difficult to control diabetes, we have them check their sugars 3 or 4 times a day, but it's most relative to meals because we just assume that the PD prescription is background glucose intake, and the additional caloric intake that is occurring is with meals. So we still have them check it around meals. Having said that, if we do advise our patients to use more regular insulin, for example, if they are on insulin on days or times that they would use a red bag, 4.25% dextrose, or a higher concentration of dextrose than their background prescription. Generally, to have them use 2 to 4 units of regular insulin, more for every step up in concentration is a good rule of thumb. How that you still need to make sure that it works for that individual patient.
Okay. Any more questions?
Questions queued up at this time.
I'll read another question here from the chat box. Is it ever appropriate for the patient not to be on an ACE inhibitor / ARB?
You have a reason not to have it, and the reasons for a patient not to have it, for example, for ACE inhibitors, the most important complication is cough. And if the patient has cough, they will not be able to tolerate an ACE inhibitors. In such a patient, you can try an ARB. The other indication, of course, the other problems that you can potentially get into is, particularly in patients who have no residual kidney function and who have high intake of dietary potassium, kalemia can sometimes be a problem. Having said that, at least in my clinical experience, it is a very uncommon problem. The third issue is low blood pressure. If someone has blood pressures of 90 or 100 systolic, or 110 systolic, or they get dizzy, you would not want them to have ACE inhibitors, ARBs on board. The 3 clinical settings in would be careful. So tolerance, getting a side effect of the drug like a cough, high potassium, and low pressure. In my clinical experience, that would mean that about 80-85% of our patients will be able to tolerate that. That number is never 100%. Any large program.
Thank you, Dr. Mehrotra, and thank you also, Sarah. If there are no more questions, we'll go ahead and stop here as we are at the top of the hour. I would like to take a moment and thank everyone again for your participation, and to especially Dr. Mehrotra for taking time away from his very busy schedule to answer questions and present to here today. Be sure to join us for our next webinar that's scheduled for Friday, December 7th. That webinar is going to be Understanding and Achieving Adequacy in PD Patients, and will be hosted by our very own Dr. Mel Seek out of Ocala. A reminder for those nurses in attendance, you are eligible to receive 1 continuing education credit for today's presentation, as well as 1 credit for each of the previous webinars in this series or in our last series as well. And those recordings are up for you to watch if you missed any of those. I will send out the Star Learning course code to each of you that participated in today's call in a separate email. It'll go out at the beginning of next week once the courses are loaded in Star Learning. Thank you, everyone, and have a great day.